Director of Policy at the National Health Council. For those of you who may not know this, the Spina Bifida Association is a member in good standing of the National Health Council. The National Health Council is a wonderful organization that fights on behalf of organizations such as SBA and the patients that they all represent. And so they're really focused on trying to improve health and for people with chronic conditions and disabilities. And I'll let Jennifer tell you a little bit more about the National Health Council, and she's going to dive into a topic that has been of interest in our community about your rights to access and care during the COVID-19 scare. So Jennifer, with that, welcome to SBA. We're glad to have you.
Thank you so much, Sarah, and everybody on the line and my fellow panelists. I really appreciate the time to be here today. As Sarah mentioned, I am Jennifer Dexter. I'm the Director of Policy at the National Health Council. For those of you that aren't familiar with the National Health Council, we were founded about exactly 100 years ago to bring together diverse organizations to forge consensus and drive patient-centered health policy. Our main work is to provide increased access to affordable, high-value, sustainable health care. We're made up of about 140 national health-related organizations and businesses. Our core membership are all the nation's leading patient advocacy organizations, including SBAA. Other members include health-related associations, nonprofit organizations, including providers, research and family caregiver groups, and businesses representing biopharmaceutical, diagnostic, device manufacturers, generic drug, and payer organizations. What makes me uniquely qualified, I guess, to talk about this issue is that I come from a disability rights background and have long known of and appreciated the work of SBAA in that area. And so this is a nice, this issue is a nice melding of my background and interests. So I'm really excited to be here to talk to you about this important topic today, which is the issue of making sure that people with disabilities and chronic conditions have access to the services, the devices, and the care that they need, not just during COVID-19, but broadly. And I say that specifically because historically, access to healthcare for people with disabilities and chronic diseases has been an issue. They have been denied access to health services due to conscious and unconscious bias. And it's a long-standing issue that's come to the forefront lately, clearly as we as a world have addressed the COVID-19 emergency. So as I mentioned, health systems historically have struggled with undervaluing the lives of people with disabilities. This has played out in a lot of ways. One of the examples I like to use is organ transplants. For many years, this is something that a lot of, particularly those in the intellectual and developmental disabilities world, have fought for. Because organ procurement doesn't nearly meet the need that's out there, there are a lot of protocols and rules and prioritization that goes into deciding who gets an organ and who is next in line for a transplant. Historically, people with intellectual and developmental disabilities have been put lower on the list or flat out denied care because there's some unfounded assumptions about either their quality of life or their ability to adhere to all of the rules and regimens that, of medical things that have to happen after a transplant. So part of the civil rights history of people with disabilities is making sure that access to healthcare was part of all civil rights legislation that's moved forward. And the three kind of pillars right now that civil rights for people with disabilities in the healthcare world are built upon are the Americans with Disabilities Act, Section 504 of the Rehabilitation Act, which prohibits discrimination in entities that receive federal funding, and sections of the Affordable Care Act that reaffirmed people with disabilities' rights and access to health care. So as I mentioned, COVID-19 has really put the spotlight on these historical issues, particularly around the possibility of rationing and shortages of medical equipment, such as ventilators. The latest topic seems to be dialysis, fluids, and more have really been front and center. We've seen a lot of coverage of this in the press, a lot of discussion among advocacy groups. And the core of this really is something called crisis standards of care. And basically what this is an official thing that happens when there is a substantial change in the usual healthcare operations and level of care that it's possible to deliver, either through something that's pervasive and all over the place, like this pandemic we're currently living through, or something that's local and specific, like a natural disaster, like an earthquake or a hurricane. So in those cases, the healthcare system isn't able to operate kind of business as usual, so they invoke this thing called crisis standards of care. It's justified by specific circumstances and is formally declared by a state government in recognition that the crisis will be in effect for some period of time. The formal declaration that crisis standards of care are in operation enables a lot of things to kick in, a lot of legal and regulatory powers and protections, things like protections for healthcare providers in their daily tasks of providing, allocating and using scarce medical resources, and using alternate care facility operations and things like that. So these are the rules that go into effect when something goes sideways, as it has now. The attention and pervasiveness of the current emergency has kind of shone a light on these crisis standards of care, and many have been found lacking at various states. One of the things I do want to make it clear relatively early in my talk is that while there is severe potential for bad situations with rationing and these levels of care, we have not yet had reports of bad outcomes related to rationing of services or equipment. Not to say they aren't out there, but we appear to have not yet hit those spots where some of those decisions have had to be made. The concern is that the policies in place, either in the near future, if we do hit those situations in a local area or broadly where we continue to have these shortages, it could present a significant issue. I have also been very focused on the fact that many of these policies and procedures that are in place are long-term. So even if we are able to get through this crisis without having to make decisions about rationing ventilators, does not mean that policy wouldn't be a problem the next time we face some other issue. At the end of the day, what I want to leave you with is that decisions about access to healthcare should be based on solely the individual's ability to survive the healthcare situation that they are facing right at the moment. Should have nothing to do with perceived quality of life or likely lifespan unrelated to COVID-19. We want to make sure that the policies reflect this so that patients and families and providers have the right guidance when making hard decisions and that patients are protected, even against unconscious bias, either with an individual situation or within the system. I've really been focused on the fact that we want to make sure that we have good information for an ER doctor who's having to make really hard decisions so that they are protected and feel safe and feel like they have the information they need to make the right decision for the patient and for themselves. So this has played out in a couple of ways lately. In response to the disability community's really wonderful and really strong advocacy, the U.S. Department of Health and Human Services, and specifically the Office of Civil Rights within HHS, published a bulletin on March 28th. I can't believe it was that recently. It seems like it was forever ago, to ensure that covered entities followed civil rights laws. The guidance explains that any entity funded by Department of Health and Human Services, which is pretty much any hospital, can't deny people with disabilities medical care, and I'm going to quote this just so you have it, on the basis of stereotypes, assessments of quality of life, or judgment about a person's relative worth based on the presence or absence of disabilities. It also discusses the obligation that hospitals have to ensure equal access and effective communication for people with disabilities. So it's a little bit broader than just the rationing and crisis standards of care discussion. Because of that guidance, one of the things that drove that was that there had been at that point, I think 2 states had lawsuits filed against them saying that their standards were not appropriate. The first one was actually the state of Alabama. And since that guidance has come out, and because of the great advocacy of everybody working together, we've had some really significant success. And we're hoping that this is kind of the blueprint for going forward. The Office of Civil Rights and HHS announced that it was doing a compliance review of the state of Alabama based on a complaint that had been filed by disability advocates, and that they had decided to drop that review, but only after the state of Alabama had removed their ventilator rationing guidelines that were the ones that were discriminatory against people with disabilities. They had stepped in after the Disability Rights Group had filed suit, saying that the criteria for mechanical ventilator triage that the state had put out in 2010, so keep that in mind, that was way before the current crisis, allowed for denying ventilator services to individuals based on the presence of intellectual disabilities or dementia. The Office of Civil Rights said that as a recipient of HHS funds, Alabama is required to comply with all the disability and age-related civil rights statutes that I mentioned earlier. And as part of the agreement, the state agreed to remove all of the links to that 2010 criteria from its websites and to comply with the civil rights laws. And it was further agreed that they would clarify publicly that the 2010 criteria are not in effect, not appropriate, and that it will not, in future guidelines, include similar provisions. Singling out certain disabilities for unfavorable treatment or using categorical age cutoffs would not happen. And it will also not interpret the current guidelines to support that. So really, it was pretty much a pretty significant victory to have Alabama step back from that. But I think it also shows the reality of that those 2010 guidelines have been sitting out there for quite a while before this crisis hit and kind of called attention to them. There are currently open complaints in many states. You can go to the next slide here, I think. There's a list there, but it's Washington, Alabama, Kansas, Tennessee, Pennsylvania, Utah, New York, and Oklahoma. And those are the ones with formal complaints right now. But in addition, there's a lot of press coverage. There's a lot of discussion around this in California right now and some other states on issues that are in place in different states where we may not have a complaint yet. So I would expect that list may grow slightly. In the last few weeks at the national level, hundreds, and more than hundreds of national disability, aging, and patient advocacy groups have come together to send a series of letters to the Office of Civil Rights. First of all, thanking them for the guidance that they put out and their work in enforcing that guidance, but also to ask them to provide more technical guidance, more direct guidance, and to continue their enforcement and oversight work. So to force the hand of more states and get more outcomes like we had in Alabama. At the end of the day, I know this is really scary stuff. But as I said, I think if we are able to do this right, we're presented with an opportunity to make some changes that will really benefit everyone in the future. So let's go to the next slide. Thank you. So I know you get presented with a lot of scary stuff, and I guess the next question is, what can I do about it? And that's really what we're going to cover now. I think there's 2 levels to this. I think there's what we can do individually to make sure that we know and protect our own rights. There are things that we can do to the system and working with states and hospitals to make sure that things like policies and oversight and procedures change. And it's kind of 2 very different things. So I want to start with kind of knowing your individual rights. It's one thing to know the technical nature of it, but I'm going to run through a couple talking points that I think will help everyone to really, really understand the thought behind what these laws do. The first is to make sure that not only you understand your individual rights, but that your family and loved ones do too. I know in speaking to a lot of friends and family, I think people with disabilities and chronic diseases are particularly concerned about what might happen if they were to experience COVID-19 and end up in the hospital. They're more likely to experience more significant effect of it, and may not be able to, in the moment, be a self-advocate. You may not have a voice at the moment. So making sure that you have either people around you or ways to communicate and advocate is really important. So making sure that your family or your loved ones or a friend or somebody understands this as well is really important. So here's, the disability groups that have been working together on this issue for a while, boiled down what rights are and should be and how they should be communicated. And I'm going to run through those for you now. And these are just kind of a series of statements that I think help us get our head around how to speak about rights. So the first is that the lives of people with disabilities are equally worthy and valuable as those without disabilities. I think this is a group that innately gets that and understands that, but being able to articulate it is important. People with disabilities must have an equal opportunity to receive life-sustaining treatment. The fact that an individual with disability requires support to live their daily lives should have no effect on whether that individual can respond to treatment. That gets to that issue of kind of how you view somebody's quality of life, perhaps, but that's really important. So doctors and triage teams, and triage is kind of the prioritization that happens, must not employ assumptions and stereotypes about the worth or quality of the life of a person with a disability in making decisions about medical treatment. They also should be self-aware enough to know that they are not free from conscious or unconscious bias in making these life and death healthcare decisions. Given the reality that people with disabilities have long experienced discrimination in receiving medical care, it's really important for providers to be told and to understand those things that can be underlying these decisions. To avoid discrimination, doctors and triage teams should perform a thorough individual review of each patient and not assume that any specific diagnosis has an effect on their prognosis or their survival without an analysis of current and best available objective medical evidence and the individual's ability to respond to the treatment. So this goes back to what I was saying earlier about making sure that decisions are made based on the individual's real chances of recovering from the infection or the issue or the virus that they are experiencing right in the moment. One of the things that people have some fear about that we've heard a good bit about that I think it's important to understand is that doctors and triage teams must not reallocate ventilators of individuals with disabilities who use ventilators in their daily lives and come to the hospitals with symptoms of COVID-19. So in other words, if I use a ventilator not related to my COVID-19 symptoms, I shouldn't have that ventilator reallocated to treat a COVID-19 person that is using it. I have not heard too many instances of that actually happening, but I know that that is something that people are very concerned about and may be a barrier to people, seeking medical in a hospital. And finally, it's just knowing the laws to talk about. Federal disability rights laws, the ADA, Section 504 of the Rehabilitation Act, and the Affordable Care Act broadly protect people with disabilities against discrimination in receiving medical treatment. These laws apply to hospitals experiencing equipment, bed, staffing shortage during the pandemic, as well as state policies. So reminding people the fact that the current situation and the unusual situation we're in does not preempt civil rights laws. So then the next question is, how do we keep people from having to have these individual advocacy situations? How do we change the system so that they better address the healthcare needs of people with disabilities and chronic conditions? It's advocate, advocate, advocate. If you are able to, it's a really good time to talk to legislators and decision makers about your concerns about these crisis levels of care and what they might mean in terms of access to healthcare for people with disabilities. I think it's an important thing to just make sure that we're always talking about and continue to talk about even when we're on the other side of this discussion. So individual, straightforward advocacy that SBAA always is wonderful about supporting and pushing is an important part of this. But also working organizationally. I think particularly for those of you who are part of a local or a state chapter, this is a great opportunity to really band together as disability advocates to work with the states and to work with the hospitals to make sure that the policies they're relying on don't discriminate. While this isn't something that can happen quickly, likely may not happen during this crisis, but certainly this crisis can drive discussions. If we work together in the long term to make sure that people with disabilities are engaged in developing and reviewing standards of care, they're going to be better. Whenever we can get the patient's voice infused into those decision-making processes, the better the outcome is. Nothing about us without us. That's just a critical portion of this. And because there is so much attention to these crisis levels of care and resources and rationing and allocation, it's a good time to try and get to the table to drive those discussions. And the more you're able to work with individual advocates, other organizations, be supportive, the more chance we'll have to be the folks sitting at the table reviewing those when we have the chance to. So I think that's really important, is to not let go of the fact that we really should be at the table with those state health departments, with those hospital systems and individual hospitals as they're developing, reviewing, using these policies. I suspect when we get to the other side of this crisis, there's going to be a lot of attention paid to getting ready for the next one. And this is the time when those things are going to be reviewed and revised, and we have to be there with them. That may seem really daunting, particularly for those of you that are maybe an individual advocate out there, without a lot of support other than this wonderful organization. But I encourage you to work with groups. Just as an example, some of the groups that are working state by state are the ARC, the Disability Rights Networks, and others. You really don't have to be in this alone. And I was mentioning to Sarah and Sheila before I got on that I'm going to follow up and share with you guys a couple of resources that I think will be really helpful. The first is a kind of clearinghouse that's been created at the Center for Public Representation, where you can find information about everything that's happening at the state level, all of these different complaints and lawsuits, but also can find individual resources. One of the things that the National Health Council signed on to that I think will be really useful in the longer term is a series of guidelines to say what should go into a good crisis standard of care. And so it's designed for advocates like you all to be able to, when you're able to get to that table, when you're able to talk to decision makers about what these policies should look like, here's a checklist, here are things you should consider. And I'll send that out as a resource after. And they have just a really nice clearinghouse. There's some plain language kind of guides that the ARC has put out that are very useful, and some legal information that disability rights networks have put out that'll be very helpful. So I'll put those together and share those, and so we're able to all have them. With that, I think I have covered my piece, a little shorter than I planned, but I'd be happy to answer any questions, or if you guys have anything you'd like me to talk more about, to clarify, I'd be happy to do that.
Thank you, Jennifer, very much. That was very informative. We do have a few questions, and I'm sure others will probably add some more as we get going and answering these questions. The first one is, are people with mental, developmental, or physical disabilities like spina bifida more likely to be put lower on the list?
You mean for ventilators? And yeah, I think if right now many states have policy, and hospitals have policies in place where somebody with a disability could very easily end up lower on the priority list if they were having to make a decision about whether patient A or patient B gets a ventilator. It's not a great truth, but it's a truth. We are fortunate that we haven't seen that play out yet or gotten to that point that we have heard about yet. But those are out there. It's not everywhere for sure. And it's and I do want to emphasize that it's not a universal thing. The other side of it is, it's one thing to have a policy in place that says somebody with a disability would be considered secondary for a ventilator or something like that. There are a lot of places where there isn't enough guidance to specifically say they should be considered on an equal footing. And in that case, you're very much at, the concern would be a doctor who, through no malice or no, just because of unconscious bias that they have, may make a wrong decision and choose to give that ventilator to somebody without a disability versus somebody that did. That's a concern. That's one of the things I think is really important about having these good policies in place, is helping that individual. I keep thinking about the ER doc who's been working a zillion hour shifts and having to make really hard decisions, and putting them in that situation. They need help. They need guidance. They need things to help them make the right decision that they're going to feel good about, that is going to be the right decision. And it's not saying people aren't going to have to make hard decisions. I mean, we could very well end up in those situations.
Right. So the next question has to do with yearly wellness check-ins. This person writes that her sons, who has spina bifida, had a wellness check-in scheduled and it was postponed. When I reminded them of his condition, they told me that unless I had an immediate concern, I cannot bring him. Fortunately, he is doing well. They added that the doctors are only coming in 1 day a week based on the CDC recommendation. Is this argument valid, or is my son being discriminated against?
I'm not going to make a legal argument for this because I don't have an answer, that answer. But what I will say is that given the situation we are in, and given the fact that the wellness visit, it is probably in line with a situation a lot of people are in, which gives you some legal standing there. That being said, given somebody with spina bifida may need that wellness visit more than somebody without it. One thing I would encourage, one of the things that has happened as a result of this is that the governments have and insurers have allowed more alternative ways to work with people. For instance, telehealth. Instead of an actual wellness visit, is there an opportunity to do a video chat or a phone consultation to at least address immediate concerns? Previously, a doctor would not be reimbursed for a visit that was just by the phone. They would have to have a video with it, for instance, or things like that. It's much easier, and there are ways for doctors to be reimbursed for those kind of visits now. And I'd maybe encourage you to work with whoever your coverage is through to pursue that. It's a time to think creatively for everybody. So that's just something out there as a potential opportunity.
Well, I know from my own experience that I was scheduled for a physical during this time, and it's been postponed as well too. I don't, and again, I don't know in this exact circumstance what all the surroundings are, but in general, I also have a neighbor who's a pediatrician who they're not doing wellness checks of any of their kids, period. They're doing telehealth, and they're only really addressing issues that are, critical at the moment, or, somebody who's sick at the moment. And it's not necessarily with COVID-19, but just an earache or a high temperature or a stomach bug or whatever the case is. So
everybody's trying to avoid contact.
Yeah, I think that in general, most of at least in Virginia, most of the physicians' offices pretty much are closed at this point. And they are doing telemedicine as a backup. And they're telling us if something's critical to go to the ER, not to come. They're not seeing patients. So I think in general, the reality is that's probably what most people are facing. And if she has any kind of issue, if her child has any kind of issues, she should then definitely pursue
Absolutely.
a televisit or advocate on his behalf and push the issue. But if he's doing okay, then I think it's probably safer to be on the safe side of social distancing instead of going in for a regular checkup anyway.
Yeah.
But again, I don't know all the circumstances around this particular situation, but that's in general. I also wanted to ask you a question too around telehealth, because for a long time we have thought that telehealth could be something that could be beneficial to our population, because transportation tends to be an issue for a lot of our, particularly our adults. As you know, you and I've had this discussion that our adults have particular challenges in finding physicians that are willing and capable of treating them, number one, but also, for some of our adults, it's very difficult for them to get into a physician's office anyway, because of transportation issues and other issues. And so telehealth to us has always seemed like something that could be beneficial. Now that this genie is out of the bottle, so to speak, because as we have seen, it can work, and physicians can be reimbursed for this, and it can handle a lot of different situations. What do you think about telehealth in the future and how it could impact people with disabilities?
I think it could be huge. I think we're at a very interesting point, and I feel like I've turned a corner now, and I'm starting to think about some of those longer term implications, and telehealth is definitely one of them. I do believe that when we're on the other side of this, a real opportunity to say, we have this kind of weird microcosm test of using telehealth for a broad swath of people very quickly in an unusual way that we hadn't experienced before. How did it work? How did it work for the providers? How did it work for the patients? What are the good things we can take from this? What are the things that need to be addressed or added? And how can we do that? I think, one of the things at National Health Council is we have, the patients lead the way, patients' voices lead the way. But we also have in membership some provider groups who work really closely with some of the provider groups and insurers and things like that. And I think there is also a discussion to be had about how do we, now that we've kind of, as you said, let the genie out of the bottle, how do we go back and build in some protections and some safety things, and making sure that, telehealth is done right if we're able to expand it or offer that opportunity. What I don't want to see, and I think is really important, is to have people with disabilities be the only telehealth kind of group because of those things like transportation issues. I think it's letting people off the hook a little bit. I want to come out of the situation where we use telehealth in an appropriate way that works for providers, that makes the life of an individual seeking care easier, and provides an equal level of comprehensiveness of care. So I think those are kind of the longer term discussions I think we need to have on the other side of this, because I really do believe that's going to be one of the things, like many things, that are going to be very different in our world after this. I feel like we're going to go back to the days of, house calls, not really, but people are having appreciation for the variety of ways they can interact with their doctors. And I think for people with disabilities who, have other barriers to maybe accessing a doctor's office, being able to do a telehealth visit doesn't let a doctor off the hook for not having an accessible exam table.
Yeah, I agree.
But
I think
it's a great way to get a chat with your doctor on an issue you're having without having to deal with the barriers.
Right. So another question that came around telemedicine was, would telemedicine be an appropriate replacement for the patient that was denied access to the wellness visit? So the thing about it is, is telemedicine does not work in every single instance. I have a friend who woke up one morning with a ruptured eardrum. You can't get in and look at the ear to see the extent of the damage on a wellness visit or on a telemedicine visit. You know, there are things like if you don't have a blood pressure cuff at your house, you can't take your blood pressure. And there are standard things that doctors do that you can't do in that telemedicine visit that could be done in an in-person visit. Yeah. And all of those things kind of give a better picture of the overall health of a person. You know, you can stand on a scale, but it's easy to fudge your weight, you know. And if you're in a wheelchair, you may not be able to stand in a chair anyway. So, you know, well, obviously you can't stand in a chair, but I mean, you may not be able to get on a scale in a wheelchair and get your weight. So there are some things that, you know, you kind of have to go to where the doctors are to get those kind of measurements done. But in particular, if you're having a very specific issue and you need to talk to a doctor, it's a great way to at least start that conversation, and then the doctor can say, yeah, I really do need to see you.
Yeah.
You know, so I don't think it fits in every situation, but it can be helpful.
Yeah, and I agree. And I think the difference in this moment is very different than it would be a year from now. Yeah, that discussion. I think we're also going to come out of this thinking creatively about how we use different, you know, an attendant that could certainly be provided a blood pressure cuff and a thermometer and you know, equipment by their, and then could just simply be the kind of hands of the doctor on those visits.
Right.
There are a lot of interesting things you can do, but I think at this moment, it is an appropriate way to substitute a wellness visit. But I would also say push for, you know, I'd like to come in for a 6-month one after after we're clear, that kind of thing.
Yeah. So another question came in, is having a caregiver come with you for a procedure or issue protected during this time, as long as they themselves are healthy, or is it a hospital by hospital decision?
It's a very interesting question. Actually, right now, there is, it's kind of an open question. There's a lot of concern about allowing an attendant in with somebody with a disability that's admitted with COVID-19. So, because right now most hospitals have a no visitor policy. There is guidance in that guidance I mentioned that talks about hospitals need to allow attendants to come in and help the individual, you know, with all the other stuff of life while they're undergoing that hospitalization. It's still being kind of sorted out. It seems to be a concern and an issue. OCR, the Office of Civil Rights, has indicated that they believe that it is appropriate and right to allow attendants to come in and to work with an individual who might be hospitalized. Yeah, I think that's a very difficult question right now, but one that's being sorted out as we speak. I think the rationing issue is almost clearer, but if I was in that situation as an individual right now, you do have some standing to be able to say, hospital, you need to allow my attendant to come in and be with me.
What if it's not an attendant but a family member?
I would say you'd have to make the guidance is specifically for personal attendants. Now, if the individual, you know, if the family member is acting as a
personal attendant,
needs somebody to communicate, to, you know, whatever, do activities of daily living, I would think you could make the case that one family member could be identified as that person. As I said, it's a very open, still being sorted out question right now.
Yeah. There's a lot of concern in our community too about, particularly with our adults who live with their aging parents who may themselves be at risk. If the adult gets sick and goes into the hospital and the parent is still part of the caregiving team, but is at high risk, you know, would they be allowed to go in with their child? That's a big concern right now too. So I think, I think that's something that we're going to have to look for some guidance on. because if those people have been playing the role of caregiver, then there's an argument to be made that they should be allowed to go in. But then how do you protect them? You know, it's just a big question. But at least for our aging population, it is a question that needs to be answered. And I'm sure it's not only within our population, but other populations as well too.
Yeah. There is some legal precedent, you know, or not legal precedent, but guidance around, you know, that they should be allowed to be there. I think there are significant, I think you hit it right on the head, Sarah. There are significant issues around what risks that raises, value versus risk. Yeah, and I think that you're going to have a hard road to hoe to fight for that entry in any hospital. I think it's going to be no hospital is going to just okay that. They're going to have to really advocate to do that. That's not going to be particularly easy, but.
Any suggestions of how to prepare to, handle it, whether it's your aging parent that's your caregiver, your family member, or you have a personal attendant, and you're concerned that you could get sick? What could you do in advance to kind of be ready in case you are? I
think you need to really have personal planning around what backups, what things you might rely on, things you might need to have in place, who gets called, who comes in, who can help with the outside stuff, depending on the situation. I think you need to play this, really it's about individual planning at this point. I think people need to be prepared to be separated from somebody who's sick, one way or the other. And I have, I think, looking really closely at, I'm going through this in my own family right now. We're in the middle of this, having to maybe get an aid in for my in-laws. And we're using the CDC guidelines to find ways to put things in place to make sure that my in-laws are protected and the aid that's coming in is protected. Starting, those backup plans and having somebody in place that can help in this requires that you also think through the safety precautions, and CDC is obviously the best place to go for that. But really, I think that's my best advice at this point, is have contingency plans for being separated for some period of time.
Follow-up question. No, there's a follow-up question about, is that concern still valid if it's for a non-illness but a preventative care CT or ultrasound? So I think what they're asking is, can the hospital stop a personal attendant or a family member from going in with a more of a routine kind of test that's not COVID related?
That's a really good question. I will say, honestly, I think I would have to do a little bit of research on that.
Okay.
I would think that my experience, at least, is that I think most hospitals are putting those things off, or most hospitals that I'm aware of are limiting access to the building total.
Yeah.
And I expect would, at the very least, require it be a limited situation with certain precautions in place. There would have to be some, protective measures that went into place, because they don't want outside. Basically, their concern is outside people bringing it in as well in non areas. So I would think it would be a long conversation. I think in terms of the actual legal right to access, I'm not sure for that at this moment in time.
Well, perhaps some of the follow-up sources you're going to give us might have some guidance on that.
Yeah, I'll include some of that. Yeah, I hadn't thought about that. I put a good bit of thought into the issue of if somebody is diagnosed, you're getting access. But I hadn't thought about other procedures in the hospital, and especially right now as more hospitals are opening up to elective procedures.
Well, I think that this individual just wrote back and said that she was told it was okay, but worried about being turned away at the door if she was misinformed.
Yeah,
So I think you go with the intent of doing, and you'll just have to deal with what they tell you on site. And most hospitals are gonna, hopefully they're going to be able to be reasonable during all of this, even if they're not always 100% on the same page. But it's, I've often asked for them to send me a follow-up email in writing with their instructions, and then that way I have something in writing from someone from the institution that I can take with me to kind of show as my proof. So that might be an option to kind of help make you feel a little bit better. And even if you do that, there's no guarantee, unfortunately, at this point.
And I would have a conversation with them before I even left the house around what precautions they want in place to make sure I showed up with the right things. For instance, they may take temperature when you get there, and if you have any temperature, they won't let you in. And who knows, you may have a slight temperature and not feel it. So taking a temperature before you leave the house so you can be prepared for, things like that. What kind of mask do you need? What kind of clothes should you wear? Having a discussion before so you don't show up and, face some obstacle there.
Yeah. It's a good idea to have in your preventative planning too. I think now planning is critical for our community, because you have to be able to tag somebody if you get sick to help take care of the individual that you're caring for. And that's even, not even for relating to somebody with spina bifida, but anybody who could be likely to become sick. So I think, you have to kind of have a plan Z in place at this point.
Yeah, unfortunately.
So, all right. Well, okay. We have one more that just came in. Doing an ultrasound or MRI is not elective for most people. We hopefully will have an MRI that is put off recently to check and see why this particular individual is losing feeling in her hand. So I think that's just a comment to remind us. I did say elective, and it may not have been elective. It may have been something that was mandatory for another condition. So thank you, Patty, for reminding us.
Sorry, I misspoke too.
Not everything is always elective if it's not related to COVID. So there could be a bigger issue going on. So
exactly.
So thank you for that reminder.
Yeah, and I think the other thing with this, I think the other conversation to have is alternative locations for that kind of procedure. Hospitals are just tough places to be right now.
Yeah. It's been really interesting. I had to go get labs drawn yesterday, and the labs gotten really good at figuring out how to social distance. And now people are waiting out in their cars and being called in when it's their time, so to speak. So it really kind of cuts down on your having to sit around in a waiting room. It's like maybe they'll keep that too after the fact, because that's really helpful. Sitting in crowded waiting rooms is not always a fun thing anyway.
I feel like there's a whole discussion to be had about what are the good things that we've learned in all of this around what's possible and what isn't.
Yeah, I agree. And you have to look for your silver lining somewhere in all of this, I think. So
yeah.
But if anything, it's forced the medical community to get a little bit more creative than they have been, instead of, oh, this is the only way you can do it. No, there are other ways you can do it. You just have to think about it. So that's good. Well, listen, thank you, Jennifer, very much for sharing your time with us. We appreciate it. And this is recorded, so I'm sure that people will be checking this out later on in the evening when they're finished with work. But we do appreciate your expertise, and thank you for sharing it. And we look forward to hearing more from you with the sources that you mentioned.
And thank you so much for having me and for the wonderful work that you all do. I really do value it.
All right. Well, you take care, and you have a wonderful day.
You too.
Bye, everyone. Take care.
Thanks, everybody.